Welcome. I'm Dr. Patrick Denard from the Oregon Shoulder Institute, and I'm joined by two superstar surgeons, and Dr. Tony Romeo from Chicago, Illinois, and Ty Brolin from the Campbell Clinic. We're going to talk about maximizing fixation and reversal arthroplasty with a modular glenoid system. We're going to go over a series of topics over the next 20 minutes or so, and I want to engage these two excellent surgeons on their preferences and how to achieve maximal fixation. So let's start off and hit central fixation. So in a primary case, Tony, what do you prefer? With the modular glenoid system, we can use a screw or a post based on the modularity of the system. What's your preference and why?
My preference is the post. For years, I used the screw in a different system very early on in the reverse arthroplasty world, and I did like it. It's very nice, but more than 50% of my cases now, I'm using an augment. And so for the flow in the operating room and for the consistency of the assistance that we have available, I've just stuck with the post, and I've learned how to use that effectively in a variety of different situations, including revision cases, and it's worked very well for me.
Awesome. Ty, how about you?
Yeah, I still prefer the screw fixation. I really do like that immediate gratification. I think what's important is the screw fixation with the MGS, with that hybrid that allows for the biosync ingrowth to maximize long-term stability, as well as that immediate fixation. But I think Tony has great points in a lot of these cases for augments, of course, using post, which is becoming more and more of my practice.
Yeah, I'm glad you pointed out that fact of the screw really being kind of a screw post. You can see it really nicely in this picture. Mm-hmm. And this is a paper we published recently with Mike Bursick as the lead author, where we actually looked at screw versus post with these constructs. And bottom line here is that we found it really doesn't make a difference. It's based on surgeon preference. We had a very low rate of failure regardless of what you do. So I think it's really dealer's choice. So regardless of screw or post, now talk to me about fixation. Do you go bicortical? Do you go unicortical? And does this vary if you're using a post or a screw? Tony, how about you?
So I think this is a lesson I've actually learned with the post that unfortunately was an issue with one of my patients, and that is that if you really need strong fixation, you have to go bicortical. And in the cases where you use an augment, particularly a 20-degree augment, I don't believe that we reproduce the biomechanics so that the forces are even across the glenoid face. I think we still have some torsional load. And if you try to put a 20-degree augment with a post that doesn't go through the second cortex, you increase your likelihood of failure. So the way I look at this is, for me, in cases where I have rock solid bone, you can use the post just short of the second cortex. But if you have any concerns whatsoever, you should go through that second cortex, and you'll have that same kind of great feeling that Ty just talked about when you hammer that down and it's seated in place and you know that it's not going anywhere.
Yeah, I think that's a good point. And traditionally we were trying to contain a post within the glenoid vault. But you alluded to this, the biomechanical data really supports that regardless of a screw or post, it is advantageous to go bicortical. It's probably actually more advantageous perhaps with a post, as we can see in this data here. But either way, it does appear to be advantageous to go bicortical. How about
I think you're right. My personal experience is that I think it's even more important if you decide you want to use a post, and if you really need strong fixation, you should go bicortical. I think with the screw, if you get good compression in the initial fixation, you might get away with that effectively without going completely through the second cortex.
Right, and the nice thing with the modularity here is you can really select your precise length to get that exact amount. So I think that's a really nice feature of the system, having that in 5mm increments. How about baseplate contact? I think this is an area of controversy, Ty. What's your goal for contact? And does this vary if you're using a central screw or a central post?
Yeah, that's a good question. And so for a non-augmented standard case with limited deformity, I still try to get 75 to 80% contact with the base plate. Prior to metallic augments, when I was using bone graft, I would always shoot for at least 50% contact with that native bone, just in case that humeral head autograft would resorb. I still have 50% of the base plate on that native glenoid to maximize initial fixation as well as long-term fixation.
Okay, so I hear you basically saying 75% and greater. Is that kind of your target?
Yeah.
Yeah, Tony, any differences there?
You know, you know how you see the word of the day and you want to just sit there and try to get it every single time? I can't help myself. I try to get 100% every time, and I'll play around with it until I do. And yes, in some of the more difficult cases, I'll be willing to drop down a little bit and maybe go down to 75%. But I mean, I feel like, shoot, I should have planned this out better. I really love the fact that we have so much adaptability with the augments and everything else. I really aim for 100% every time and feel uncomfortable when I get below 95%, but understand the biomechanics are somewhere around 75 to 75% would be just fine.
Yeah, so you mentioned this, the biomechanics is exactly as you suggested, about 75 to 50%. This is one of those studies. This particular study suggested 75%, and if you went below that, you started to have more micromotion. This study, though, they used non-locking peripheral screws, whereas this other study here from the group in Tampa looked at central screw fixation and had non-locking peripheral screws as well, but reported that 50% coverage was advantageous. So now it's a little bit of a different topic, but when you're trying to achieve contact, how much ream will you go for, and how much ream, or how will you control that depth of ream?
Yeah, so I mean, you know, the biggest thing is you got to balance reaming, establishing that base plate contact on the glenoid, as well as minimizing subchondral bone plate violation, as well as joint line medialization. So, but it's interesting, you know, we tend to try to shoot for that 90 to 100%, but prior to preoperative planning, many times when I'm using a screw and base plate, I know I would only achieve 75%. You'd still have that superior margin that was not completely in contact with the glenoid. So, you know, the biggest thing is you want to minimize the joint line medialization. I'm a big advocate for lateralization, so I try not to ream as much as you can. Now, a lot of these problems have been mitigated in the fact that we're using more and more augments.
Right, right. I think another nice new tool we have is the depth of ream instrumentation, because, you know, I'll admit many times I really couldn't tell how much I was reaming, but this new tool allows you to really precisely control that depth of ream in your patient. So you can take that max depth of ream in the planning system and then apply that. So now we're not only controlling version inclination, but also controlling the depth. And you hit it, Ty, the subchondral bone preservation, I think, is really key. Let's talk about peripheral screws now.
One sec, Pat. I think that's really important. Is, you know, when we have the VIP preoperative planning and we use that 5D targeter, we can accurately control for where that central pin is going to be placed on the glenoid. We can control or correct the version, the inclination. But the one variable that we had a hard time correcting was how much medialization that we encountered with our reaming. And so this is just another instrument that allows us to become more and more precise with our placement of the base plate.
Yeah, I agree. I mean, quite honestly, it's increased my use of the guide because of the ability to now control depth of ream.
Absolutely.
Okay, let's talk about peripheral screw placement. We have good fixation centrally. How many screws are you going to place, Tony, in a standard case?
Again, I think some of this has to do with OR flow and making sure you just do things the same way every time. And so for me, I routinely will put in all 4 screws, and I'll routinely put a non-locking screw inferiorly. And if I get excellent fixation with a good long screw, then other 3 will just be locking screws. If the first non-locking screw is not as good as I'd like it to be, I'll give it one more shot at the superior hole, and then I'll put locking screws anteriorly and posterior. And that's pretty much been our routine. And the nice thing about that is that the staff and the people providing the screws are all ready to go. And so the process moves along very efficiently.
Now, let's just talk about that, though. So you talk about a cortical compression screw and then locking screws. I think it's important to highlight that's because you're using a central post, right? So you're intentionally trying to get a little bit of additional compression. But if you're using a central screw, you're pretty much going to go to 4 locking screws, correct?
That's what I would do. That's what
Yeah.
I had done in the past. Absolutely.
Okay. And Ty, some of this data that we have had in the past says that 2 screws are sufficient. What do you tell me about that? Do you view just like Tony says, and is it based on anything you're doing clinically that makes you want to go 4, or do you do 2?
Yeah, I'm a big advocate of increased lateralization. So I maximize initial fixation. And the other thing is I don't want to ever look at an X-ray that has aseptic glenoid loosening and only have 2 screws. So I want to, and exactly what Tony said, it's the flow in the OR, the ease of the instrumentation or placing the peripheral screws. The question is, why not? It takes an extra 30 seconds or a minute to place 2 extra screws, and you maximize your initial fixation.
And I will comment that with the universal glenoid, which of course did have a different central fixation, all we had was 2 screws, and we did not see a problem with loosening. But I think that now that we've moved into the world of augments as well as lateralization, that ties exactly right. You really want to make sure you do this operation perfectly the first time, and you don't want to take any chances. And so I personally believe that there's very little downside to using all 4 screws, and you've maximized the stability of your base plate at time 0, which is what you want.
And let's put that in a context for people. How much are you all lateralizing on average?
So I think we've already kind of come to some conclusions here based on some of the clinical work that's done and our own personal experience. And we're aiming for, I guess, a bit of a mythical number of 6 to 8 millimeters for our male or larger patients and 4 to 6 millimeters for our females. And those are numbers that can be adjusted depending on the pathology you're dealing with. But we've all recognized that the lateralization is important for the best functional results and also to provide the best overall results with regards to the position of the implant.
Right. I think that's just important to highlight because these older studies on 2 screws, for instance, are often based on medialized base plates. And so when we're going 6 to 8 to maximize internal rotation, it really seems to make sense. I think we covered this concept as well, very much so already, of locking versus non-locking. So I'll just kind of go through this quickly here. There, is some data that suggests that 2 locking screws are sufficient, but again, that was based on non-lateralized glenospheres. With a lateralized construct, it does appear that 4 screws is ideal if you're going out very far. And in this particular study from Levy, 2 locking screws eliminated all failures. So it seems to be what you all are doing as well. How about screw length? How do you determine screw length, Ty?
Yeah, I used to not, but I have been planning this more recently. And the reason why is because exactly what you were talking about. You want to maximize your initial fixation, and this is done 2 ways. One is to maximize the number of screws that you can place, as well as to maximize the length of the screws. But really what I want to try to hit is that coracoid pillar, as well as that inferior pillar or that lateral margin of the scapula. So longer is better. And I do think this is important because I tend to lateralize even more than the 6 to 8 millimeters. It's not uncommon that I'm putting a 10 to 20 degree full wedge augment with +2 lateralization on the base plate and +4 lateralization on the glenosphere. And so I do think that does see a little bit more shear force and once again, try to maximize the fixation of the construct.
Yeah, I think what you all have highlighted earlier about operative flow is really nice as well. Just being able to do this ahead of time, pull the screws in advance with planning. And it also really gives you an appreciation of where the suprascapular notch is. I think sometimes we are actually close to that notch, and by going shorter, we can avoid that and also avoid the dreaded type 3 fracture. I think both of you really talked about, I heard Tony talk about this, the idea that especially inferiorly, you want a long screw. Longer screws obviously decrease micromotion, but the most important is inferior. And one of the things with this system is when you have a 24 millimeter base plate, which we are often using, I'll go back to this picture, you'll notice the glenosphere, or that is the base plate, is sitting above the glenoid. So you're typically going to be contained very well within the vault so that you're not at risk going out inferiorly, even if you're using a 15-degree divergent screw. Now stay tuned for the second half of this panel discussion, where we're really going to dive into the use of augments and how those have distinct advantages with this system.